I'm Mike Caudle. I'm chair of the Primary Care Technical Advisory Committee, and I will call this meeting to order at 10:01 on Thursday, November the 4th, 2021. The next item on the agenda is the establishment of a quorum. Ms. Cooper, would you care to do that for us, please?
Mr. Caudle is present. Barry Martin.
Present.
Yvonne Agin.
Present.
Chris Kaiser.
Present.
Rainer Mullins.
Present.
Mr. Chair, you have a quorum.
Good. Everyone's present. So we can go item 3, review and approval of previous meeting transcript. And let me say in that, that the 2-page summary states that I will not be attending the next MAC meeting, but the actual transcript correctly says that I will be attending the meeting on September the 23rd. So I'd at least like to make that note that is incorrectly stated on the summary, but correctly stated in the transcript. Are there any other corrections or modifications to be made? With that footnote by myself, would anyone like to approve the minutes then as distributed?
This is Chris. I'll make that motion.
Motion
Second,
made by
Rainer.
Chris Kaiser, seconded by Rainer Mullins. Call that for a vote. All those in favor say aye.
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 All those opposed say nay. Motion carries. We go to old business, item 4. And under that, we have a report on route crossover claims cleanup. But I noticed in reading back that Veronica Cecil had said in the last meeting that they would have a short presentation for us at this meeting. Veronica, are you on here?
I am, and I apologize. That really fell off our radar. I apologize for that. So if we could possibly move that to the next meeting, and I will make sure that we don't let that fall off the radar. I do apologize for that.
Well, I just did not want to run over on you on this if you had a presentation for us. So certainly that will be okay with me if
okay.
It's okay with the other members.
Yeah, that's fine. That's okay.
Yes, that's fine. Yes, that's fine.
Great. Sure. So I'm Veronica Cecil with the Department for Medicaid Services. The RAP work group met last on September 2nd. And since that meeting, there's actually been a lot of activity. One is that we requested each of the MCOs to designate a specific representative or contact person to help resolve any FQHC, RHC issues. And so each of the MCOs have done that. They all each have kind of taken some additional steps. One MCO developed a dashboard, and I know is piloting that with a couple of FQHCs. There's been specific work around the subcontractor issue, in particular with the dental encounters, and the MCOs are also having to report every Friday the progress that they're making with resolving any of those issues. From our side, we believe that there's been a lot of progress there. Certainly would love to hear from folks if that's not the case, but you know, I do believe that there's progress. And then there's a subgroup that was formed that is working more specifically on some of the technical system issues. And I know John, I reached out to John Inman to see if he might be willing to give us a little update on what's going on with that. And he said that he would be happy to. So John, if you're on, if you wouldn't mind letting everybody know what's going on with that group.
Yeah, sure. Thanks, Brian. This is John Inman with the Kentucky Primary Care Association. We have had meetings with 4 of the MCOs so far: Humana, Aetna, WellCare, and United. We're scheduling a meeting with Molina, but those meetings have been very productive up to this point. We've taken a bit of a deep dive into a variety of the issues that are causing, missing or incorrect RAP payments. Each MCO has been very cooperative and, have offered several different solutions to their individual systems on how they think that, some of the problems are occurring, and we're kind of working out the details of, how to correct that. We each have said that they are willing to engage in, mutual education, both from the providers and then, both reciprocating that and educating us about their systems and how they work. So, again, I think it's been really productive. We've got some follow-up meetings scheduled with each one, but they've all been very helpful trying to resolve those claims issues. And I think that we can make some good progress when we implement some of those solutions.
John, excuse me, you said Humana, Aetna, WellCare, and UHC?
Yes.
Okay.
John, this right. Oh, go ahead, Chris.
Veronica, this is Chris Kaiser. I just have a quick question. You mentioned that the MCOs have identified individuals who will be kind of the contact or point person for RAP issues. Do we know who those are? Have the clinics been told who those are?
We've had a lot of people in those groups, Chris, and I'm not sure if there's one particular person that's going to be going forward or not with each group. We've had contact with a lot of their upper management, and then they've been bringing a lot of their claims folks to those. So I'm not aware of exactly who it'll be, but they've all been participating in those meetings. And I left out Anthem also. We've participated in meetings with them about the RAP issues too. So.
We do have specific contacts, Chris. We'll shoot those out to everybody.
Okay, thank you.
You're welcome.
John, this Rayner, have the dental subcontractors been represented in this process at all, and how are they participating?
Well, Noel is here, and they've been working on a project with the visas for a bit, but we've made them all aware of issues with the subcontractors, and they haven't been represented in the individual MCO meetings, but there has been some additional work with visas, I know. So I'll defer to Noel if there's any other dental subcontractors that we're working with.
The only other subcontractor would be for Anthem, and we have not met with that subcontractor specifically. Visas does have the other MCOs, and then United, has their own dental service for Medicaid, so that they don't have a subcontractor. It goes through United. So, Avisis, with I believe it's 4 of the MCOs, has been working with us, with those MCOs, on a process, Rayner. It's going to be a slow burn for that. They're doing small, I think 3 months at a time. We tested it with one specific clinic, Grace. They were able to see some numerous RAP payments get paid, and we're now going into working with them on some other clinics through that process.
And Rayner, this is John again. At our last meeting, Veronica had asked Medicaid staff to kind of look into that as well. So I know they're working on their end, looking at some of those issues too. So you can kind of reiterate what Noel's saying. It's a slow burn, but we are definitely moving the needle forward with that.
Yeah, I will say, and Veronica's probably familiar with this because the Visas project is partnering with Medicaid because we're getting the data from the MCOs. Visas is sharing that back to Medicaid, and Medicaid is confirming whether or not a RAP was paid on that, and then the process goes on from there to make sure that all the information is caught up to speed, and any outstanding RAPs are getting reprocessed and paid.
I'm sorry, who is the
thanks.
second speaker other than John?
It's Noel, Mike.
All right.
I'm sorry I missed the last meeting, so I didn't get that update, but I know this is a very important matter for several of the clinics. And so I just wanted to get a better understanding of where that stood.
No, thank you, Rainer. It's fine. We've, in multiple meetings with Medicaid and the MCOs, continually bring up the subcontractors, that it's not just the MCOs that need to be aware of this, that we have, subcontractors that are providing services. Some of those subcontractors aren't even providing those services for those MCOs anymore when we talk about historical stuff. So yeah, we make sure that we bring up the subcontractors almost every time we're in discussion with Medicaid or the MCOs.
Well, and again, just to add to that, that there is a specific project going on with Visas where they're pulling a report on each MCO claim and then bumping, as I think Noel or John mentioned, bumping it up against our system to see if a RAP. So there is a specific project going on with that.
John, you were talking about these meetings with the MCOs. Are any of the providers part of that team that you're using to discuss things with?
No, sir. We've just established these initial meetings. We'll gather everybody in when we kind of really get into the meat of it. But we've just been discussing kind of high level issues, and they've been doing some test cases. But we plan to involve the pilot group in that when we get a little bit farther down the road. Some we've only had one meeting with, and some we've had two. So
I realize there will be time to open that up to all the providers or most of the providers. But from my standpoint, and I don't care who, you may want to include a couple of providers in those discussions to get the insight from their point of view also.
Absolutely.
Veronica, in the last meeting, Barry Martin had asked you about the large influx of prior authorizations by the new PBM. And at that time, you had said there had been a lack of consistencies with the preferred drug list between the MCOs, and that you are working with MedImpact on some prior authorization options. Could you update us on how that's going?
Yeah, we took a couple of steps that should have relieved some of that burden. But my understanding, and part of that included increasing staff to make sure that they are timely processing prior authorizations. My understanding is that the things have leveled out. We're not, when the grandfathering ended, and there was that transition from MedImpact to MedImpact and the PDL issue. My understanding is all of that has pretty much smoothed out. But of course, again, if we a lot of times don't know if there are issues unless the providers report it up. So if you're continuing to have issues with that, definitely let me know.
Barry, that was your question, is are you noticing an improvement from your standpoint?
Looks like Barry's muted, Mike and Chris.
Yeah, we have seen that ease off some. Still having just the normal prior authorization issues, but it has definitely helped a lot. Thank you.
Great, thank you, Barry.
All right. Any other thing that you want to address, Ms. Cecil?
Well, I think that's it from me. I'm happy to again take any questions or feedback.
Okay. Let me ask you this. We discussed the procedure that had been discussed back in the spring with the MAC about making recommendations to the MAC. And the last time it said that it will remain the same for the time being. To the best of your knowledge, is that still the status in that it remains the same?
That's correct. Yes. So the way that the current bylaws are is that the department will respond to recommendations from the MAC meeting within 45 days. And so as far as I know, we're staying on top of that. But again, you know, I think we're all human and sometimes things fall through the cracks. What recommendations don't get up through the MAC or from the MAC, you know, get to us. And there are sometimes that process fails, but I think we're committed to making sure that we always are responsive. And so certainly if, you know, there's ever a concern that a recommendation was made and there was no response, just let us know.
Okay. So let's go to 4B on new information, update on court ruling regarding MCO contracts. Veronica, the last time that we talked, that was, I believe, in the appeals court and still pending. What's the status on that?
Still in appeal.
Okay.
And, you know, I think that, I mean, of course, you're welcome to keep this on as an old business item, but it's going to take some time.
All right. Then item 4C, discussion regarding return to in-person TAC meetings. Is there, I know that one of the things was Charlie had talked about that the equipment necessary to do a hybrid in-person and Zoom meeting, while not currently possessed by the department, that they had selected and would be purchasing that shortly as to the September meeting, with the intention that we'll be able to go in a hybrid meeting hosted by DMS as of the 1st of January. So our next meeting won't be until January the 6th, which would be timely according to where the department is in that. Charlie, if you're on here, could you tell us what's going on?
She is not on, although her name may be appearing. It is still not up and running. If you possibly, Chair, would like to, I guess, probably plan on holding it as a virtual, and if we're able to have the space available, then we can send out a notice, obviously, and let everybody know that there's an opportunity for in-person.
Well, January 6th is not an ideal time for in-person meetings.
I know.
But what about the committee members? What's your thoughts?
Mike, this is Chris. Did we, I guess, discount having it at the Primary Care Association's location? Is that because DMS not having enough of them represented at that meeting? You know, at if we held meetings there.
I'm having trouble hearing you, Chris. I'm sorry.
So, Chris, this is Noel. We're still happy to host at the KPCA offices because we do have the technology here. You know, I know that well, for now it was discussed as doing TAC members only because of the current, you know, public health. So, you know, but yes, we would be happy to host here, Chris, for TAC members, but I don't know if it would be one of those that we had opened it up like we did originally, to where we had the Medicaid staff come here, as well as, I mean, we have the space for an open meeting, you know, for the MCOs and any other folks from the public that would want to come. If Medicaid is able to have the technology to do it from the cabinet, one of the reasons why we brought it here was because we were able to do that, where Medicaid wasn't at the time.
Understand. So I guess what I would say is that if let's just keep doing virtual until such time in which DMS, has the technology for us to do it in person and virtual to make it available. I think going forward, meetings are going to have to be accommodating both in person and virtual as well. So that's just my thought.
Any other comments by committee members?
Yeah, I agree, but I think we do need to somehow start forging towards having in-person meetings. I think the communication between DMS and the MCOs and the TAC is crucial. And I think it's really hard to have really good communication via Zoom meetings. So I think in the future, we really need to try to get to the point where we do have in-person meetings with the option for virtual. Veronica, as far as the Medicaid staff are kind of a percentage are working now out of the office versus at home, and is there any goal for eventually more people to be working out of the office instead of home?
We have a hybrid. Right now we have kind of a hybrid approach, and it really depends on your duties and responsibilities. But I would say that the majority of our staff are still 100% telecommuting. And we evaluate that regularly to make sure that, work is being performed, and we've got pretty stringent tools for making sure that there's productivity among our employees, and monitoring complaints and so forth. But, I think the state, or at least the department, I should say, is interested in seeing kind of what goes on in the corporate world. I know not necessarily for you all as providers, because you're public facing and have to see people mostly, although telehealth has helped with that. But I think we're just trying to find out what the future looks like for our employees and our work and our productivity. So, some staff go in 2 to 3 days a week. We have a small number of staff that come in every day. But for the most part, we're telecommuting 100%. And I really cannot predict the future.
So I think this is where we are right now, Barry and Chris and other committee members, is that it was our set position that we will continue to have virtual until such time as the DMS is capable of having that hybrid meeting. And so that being what it is, it would be appropriate for no change to take place and still wait for the cabinet to be able to host those hybrid meetings.
Mike, this is John. If I might add a suggestion.
Sure, John, go ahead.
We could look into the rooms at the Legislative Research Commission. I know that they're provide ample space so that everybody could spread out, and I know they have the technology to conduct them. I mean, that's where the MAC meets. If we could look to do in that space, I mean, we could take care of that if anybody wants to agree to that or think that's okay.
Any thoughts on John?
John, I'm sorry, John, this is Javon. You cut out there when you were saying, where were you recommending the space?
At the LRC, the MAC meets at the LRC, so we could look into trying to get that room or one similar with technology to accommodate everybody.
And that's a larger space where people can spread out. Is that what I heard?
That's correct.
Okay. I'm sorry, you cut out. I couldn't quite understand. I think if we can find a room that we could get people back face to face, that would still allow for appropriate social distancing for safety reasons. I agree with Barry that I think it is important to have that face-to-face communication, but in lieu of, if we don't have a space, then I think obviously we have to continue with virtual.
So I will share that the issue with the Capitol Annex and definitely January through April will be the session. But the room the MAC generally uses does not have virtual technology. And it's very difficult to get the rooms that do because of committee meetings. And but Charlie has a contact there, and we're happy to check on that if that's the interest of the committee.
I think the rooms that we were meeting in over in the health department side, on public health side, was larger than, yeah. Are those ones that are hard to get into?
They are very hard to schedule. Yeah.
I guess my thought is somewhere, it seems like more and more events are being in person with the option for virtual. And I just don't want us to lose sight that we really do need to do that. Somewhere along the line, we need to really set a date, say, we're going to really try to have this hybrid type of meeting. That's all I'm saying. As far as January, you're exactly right. It may be snowing. Our next meeting after that, it may be snowing. Those may not be the best, but I think we need to really shoot for, after the bad weather season, we should make a concerted effort to start trying to meet in person, unless we have another variant roll through.
So that would be our May meeting as a goal to be able to have a hybrid meeting through the DMS. You think that's doable, Veronica?
Certainly what we can work towards. I would hope by then we would definitely have something set up.
Okay, sounds good.
So we've got a couple meetings before then. You can keep us updated on the progress towards that end. Is that okay?
Absolutely.
All right. That's all of the old business, and then we go back to new business, and this is kind of a hybrid too. Back in May, this issue was brought up, and at that time, Veronica and Mr. Smallwood, Gene Smallwood is here. He had shown us charts based upon 20 of the states, and Veronica had stated she thought that Kentucky's position of payment for one visit on the same day, regardless of number of visits, was in a majority of the state. And Gene had offered to go back and complete the survey of all 50 states. And he's done that, and I've asked him to bring this committee back up to see if they would like to renew the recommendation to the MAC based upon this information or what, and also for purpose of bringing that information up to date for the department's benefit also. Mr. Smallwood is here with us today, and sir, would you care to go ahead?
Certainly. For those of you who perhaps were not here back in May, or just to refresh your memory, I'm Gene Smallwood. I've practiced law based here in Whitesburg for 44 years. In 2018, I served as a judge on the Court of Appeals. I have twice served as special justice on the Supreme Court. And currently I am the 7th District Representative on the Character and Fitness Committee for the Kentucky Office of Bar Admissions. And I'm serving there presently. Back in May, I did look at 20 states, and I told you at that time that I looked at 20 states randomly. And the reason that I stopped at 20 states was because the evidence was sort of overwhelming. Of the 20 states that I looked at, 15 states paid for 3 or more encounters which occurred on the same date. And those were encounters that were performed by different providers with different diagnoses. And generally one was medical, one behavioral, and one for dental. And of those 15 states, 3 paid for unlimited encounters and for services beyond the scope of the others. Some of those would have been optometry, physical therapy, or OT and speech, and dietitian. And 4 of the remaining states paid for 2 encounters only. So of the 20 states I looked at, 19 states paid for more than 1 encounter. Kentucky was the only state that paid for 1 encounter. So based upon the review of 20 states, including Kentucky, I made the conclusion at that time that I believe that Kentucky was in the minority approach with regard to the authorization of allowing billing for only 1 encounter, regardless of the services that the patient would receive on the same date. Because there was some question with regard to whether or not that conclusion was sound, I did agree to go back and look at the remaining 30 states, and I have done so. So I'm here today to report that my conclusion was correct based upon the 20 states and is certainly correct based upon the 50 states. Kentucky remains in the small minority of states which only authorizes billing for 1 encounter, regardless of the number of encounters which occur for the patient on that date. I prepared a new chart, and if you would put that new chart up for the members to look at.
I'm not sure who the host is, but screen sharing is disabled for us, and I'm not able to put the chart up until that's re-enabled.
Can we, can the host change that so that we can put the charts up?
Okay, I just made you a co-host. You should be able to do that now.
Thank you. There you can see the chart, and if you will look at that, the first one deals with, the first column deals with those states who only permit billing for 1 encounter, regardless of the number of services received by the patient on 1 date. And as you will see there, there are only states, 8 states, one of which includes Kentucky. Then the next column sets out those states which permit billing for 2 encounters which occur on the 2nd date. And the third column is for those states which permit billing for 3 or more encounters. And the reason it's or more encounters are some states, very few states, but some permit unlimited encounters to occur and billing for those to occur. Again, those are encounters which occur with different providers and different diagnoses. So as you can see, there are only 8 states, including Kentucky, which pay for only 1 encounter, 42 states which pay for 2 or more encounters occurring on the same date. And of those 42 states, 23 states pay for 3 or more encounters occurring on the same date. So in terms of, if you make this a percentage, Kentucky's in the bottom 16%, while 84% of the states pay for 2 or more encounters. And the important thing, I think, in my going back and looking at this is I discovered that this doesn't represent a new trend. The National Association of Community Health Centers in 2018 published a report, and if you could go to the next slide, or right there. In 2018, they published a report, and if you go to the next page. And it pointed out in 2018 in that published report that 39 states provided payment for 3 or more encounters occurring on the same patient, with the same patient on the same date, and 4 additional states provided payments for 2 encounters occurring with the same patient on the same date. And only 1 state, Kentucky, provided payment for 1 encounter. And it says there in the highlighted portion, only a small number of states allow an FQHC to bill for only 1 encounter, regardless of how many services were provided to the patient. So we can see that that was reported by the National Association of Community Health back in 2018. That information was made public. They put together all of, looking at all of the different states' regulations and put that in one form so that it could, individuals and entities who dealt with payment of Medicaid benefits could be made aware of that situation. That same organization, if you could go to the next slide, in 2015 also put out a publication, and they made the same findings. If you could go to the next page, thank you. And in that, on page 3, it says, the majority of states permit FQHCs to bill Medicaid for more than one medical, mental behavioral, or dental encounter per day. 40 states allow for same-day billable visits, while 5 states and DC do not. So it is evident for at least the past 6 years that the National Associations of Community Health Centers have published information to inform entities involved in Medicaid payments that 80% and more of the states nationally are paying for more than one encounter occurring on the same date, while Kentucky is not. And certainly Kentucky has not been during that 6 years in the majority of states with their approach. Kentucky is in the very small minority of states who pay for only one encounter. And as I mentioned last time, I think the repercussions of that approach most directly and adversely affect those who are economically disadvantaged, those who live in rural areas in Kentucky, which result in increased costs associated with the medical care for those individuals. And I think it perpetuates underserved areas throughout rural Kentucky. So if there's any questions, I'd be glad to try to answer any of those questions.
Yes, sir, Mr. Small. This is John Inman from KPCA. I have a couple questions.
Yes, sir.
Okay. On the states that you surveyed that billed or were allowed to bill more than one service per day, their rate setting process, is it an all-inclusive rate such as Kentucky where all the services are combined into one rate, or do they have individual rates for each individual services? So do they have mental health, behavioral health, physical health, dental? Because I know Ohio has several different rates for several different services. And in those states that do allow, two-part question, I guess, those states that do allow same-day billing for different services, are they statewide Medicaid managed care states, or are they regional managed care? And also, do those states do end-of-year cost settling or cost reports for every year?
I can't answer the third part of that in any way because I didn't determine that. I only looked at what states, because that was the way the proposition was posed, and I have heard it before.
Okay.
With regard to the others, all it provided was the information that the FQHCs could bill for more than one encounter. The indication was that the payments for more than one encounter exceeded what would be received by an FQHC in Kentucky billing for one encounter. So was it more money if you're talking for dollar, and I can't tell you what each rate would be in the 42 states that exceed what Kentucky does, certainly, but it would be more money. I can do it in a general term, but not individually, nor precisely what that amount would be.
Okay.
At the time of the other meeting, on the May meeting, I laid out that, you know, what I'm asking, what I'll be presenting to the MAC, if this committee so desires, is for DMS to do its own analysis of this, to look and satisfy itself what other states are doing, to compare it with what Kentucky is doing, and if they find that they are in the minority, to look at options or possibilities on how that could be alleviated and Kentucky become with a more mainstream majority. I think you have to respect the cabinet in this regards. they're the persons with the knowledge on this, and that's what we're asking to them, is to focus on this and to do a study and to generate a report along those lines with their own information, and certainly this information to be made available for them also, to give them a starting point. Any other questions or comment of Mr. Smallwood? Veronica, is there anything you would like to say in this conversation?
I know my question was asked, and that had to do with, in Kentucky, we have an all-inclusive rate. And so this is, I just want to make sure everybody understands, this is more than just allowing FQHCs and RHCs to bill more than one encounter. This would be a major change in our program. And because we would have to redo the all-inclusive rate, so I mean, it's a major project, and it comes probably with a budget, a fiscal note attached to it. So I get the interest, and it's always challenging when we're talking provider reimbursement. I can tell you that across almost every provider type, we've heard a need for an increase, and we get that. So, I mean, certainly if it's your all's recommendation, we'll have to consider it, but I don't really have anything else to add.
To me, I'm looking at this as an opportunity for us to provide better care. It allows us to have more funds to be able to address additional services, to have more funds to address extended hours, have more funds to address new, more available sites. We in this state, and it's no secret that we are at the bottom, or no more than one or two removed from almost every health metric that you could think about. And I think of this as a way to have the tools to start addressing that. And while it may cost more up front, eventually, with being able to move that needle on healthcare, it would be a extended savings, or at least that's my thoughts on it. How about the other members of the committee? Do you have any comments on this?
We've talked about this. I think the thing that we ought to ask the cabinet is to look at the other states that is providing multiple payments for multiple services. If there is a state that is similar to us as far as the reimbursement mechanism, how they are doing it, and see if that's a possibility. Because I know each state is a little different and unique, but I think there's 2 or 3 states that have a really similar cost-based system that we have. Can't remember if it's Iowa or Idaho, maybe Alabama.
Okay.
Mike, I don't have anything additional to add to the discussion. I guess I know in the past, there'd been some discussion of additional visits being on a fee-for-service or reduced some sort of modified fee-for-service in addition to the PPS rate to address some of the concerns. And I guess that's the only thought that I would add into the mix.
Veronica, this is John. I had one more question for you about this.
John, go ahead.
Yeah, is it okay, Mike, if I ask an additional?
Yes, John, go ahead.
Veronica, and I know everybody's favorite topic is reconciliation. When there are these different rates for different services, isn't there also a rate setting process, and you still have to have an all-inclusive rate, and that's also reconciled in those other states. And you may know that or you may not, but I believe that's also true in those other states.
Yeah, I'm not aware of that.
Okay.
But it makes sense. And again, that's the approach we took. It's all inclusive. And if there is a change in scope, if there are additional services you all want to provide, that will trigger a rate review, certainly to reflect that you all want to expand your scope. I think the whole point of this model was to have an all-inclusive rate so that some people can come in one stop to get all the services they need, and it's supposed to reflect your cost. I hate to hear that that's a barrier to people being able to come in and do that.
At the time of the May meeting, the committee passed a recommendation to be made to the MAC. And that recommendation at that time was worded this way: it is this committee's recommendation to the MAC that they request DMS to review their same-day multiple visit payment methodology and report back to the MAC comparing Kentucky's methodology of that of surrounding and other states to determine if Kentucky's approach is in parity with the majority of other states, and if not, to suggest an approach for Kentucky to become more mainstream with the trends across the country in reimbursement for same-day multiple visit payment methodology. That was what was approved last time, or in that May meeting. Would there be any comment from the committee about the appropriateness of that, or even a motion to re-adopt that to be our recommendation to the MAC out of this meeting?
Mike, this is Chris. Can you hear me?
Yes, I can. Thank you.
Yeah. No, I mean, I think it still is something that we should recommend, particularly in light of this new information that's been provided to us. That was a little bit more broader, have a little bit more data to it. So, I think we can always recommend and suggest to the MAC to consider this and put it in their hands. I think it is important, that this be addressed, and this is probably the first step. It may take a while, but yet we've got to take a first step, and this is certainly that.
Would you like to make that in the form of a motion, Chris?
Yes, I will make the motion that we bring this to the MAC for their consideration.
And is that wording that I read okay with you?
Absolutely.
All right. Is there a second to Chris's motion?
I'll second it.
The motion made and seconded. Any discussion? There being none, all in favor say aye.
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 All opposed say nay. Motion carries unanimously. All right. The next thing on the agenda is 5B, announcements from the MCOs. And going down that list is Anthem. Jennifer Smith did last time. Is she here this time?
Hi, this is Rachel Buchanan. Can you hear me okay?
Yes, I can.
Great. I'm actually going to be talking today. I'm temporarily taking over in this position. Jennifer has moved to a different role within Anthem. So this is actually my first time attending a primary care TAC meeting. It's nice to be here. I'm glad I have the opportunity. Just a few things from Anthem to share. The first is that our provider experience team has been hosting its provider experience fall webinar this week. This is the webinar for our physician groups. It's actually going to conclude today with our final presentation being held this afternoon. This year's agenda has included such topics as telehealth, information on KHI, We also gave an overview of our Anthem Kentucky Medicaid website because that has recently undergone a redesign. So we have been sharing some of the changes to the layout and the functionality of that site. Our facility consultants are planning their facility webinar as well, and that's set for December, I believe the 7th. So invitation flyers are being made up and are going to be sent out for that. Anthem's also been hosting its diabetes management webinars for healthcare professionals. The final one of these is coming up on November the 9th. And this is also a way for healthcare professionals to earn 1 hour of continuing education. On that same topic of diabetes management, we will also be sending out flyers to our members, letting them know about Anthem's partnership with LARC. LARC's a digital platform through which we are going to be offering a digital diabetes prevention program. It's going to be at no extra cost to the member. There's an app that members can use that will offer tools to track their progress, get coaching and support as they work towards healthcare goals. And then lastly, Anthem has 3 provider incentives that I'm going to touch on. We've posted those communications on our site as well. They are the COVID-19 Vaccine Provider Incentive Program, our Smoking Cessation Provider Incentive Program, and then CPT Category 2 code reimbursement. These are just incentives that we offer as a way of recognizing the work that our providers are doing to provide healthcare to our members, specifically in the areas of offering and administering COVID vaccines, providing smoking cessation counseling to our members, and then also billing the CPT Category 2 codes that just provide more detailed information on the members' healthcare visits. And that's all I have to share today.
Okay. Nothing like being new and being first on the agenda, are there, Rachel?
I know. Lucky me.
Okay. Move on to WellCare. Johnny Akers was spokesperson last time. Johnny, are you on?
I am, Mike. Can you hear me okay?
Yes, sir.
Just wanted to share that on our bi-weekly WellCare Informational WebEx forum coming up on the 12th, which is next Friday, not this Friday, but the next Friday. So on November the 12th, December the 10th, and then moving into 2022, on January the 7th, we're sharing information about our new exchange plan that we're excited about, that we're rolling out January the 1st and better. So if you have the WellCare Informational WebEx on your calendar, if you have that invite, join us. If you don't, just let me know and I'm happy to share. And that's all I have.
Okay, it was good to see you at the KPCA convention, Johnny.
Great to see you, Mike, always. And thank you for what you and everybody does on a daily basis. You're a hero. So thank you so much. Great to see you.
Okay. Well, now we all got the big head. Thank you, Johnny. Sammy Asher, I also met you at the KPCA convention. Are you here today for Aetna?
I am. Can you hear me, Mike? Hear me okay?
Fine. Yes, go ahead.
Well, and it struggled today. So just a couple quick updates. I first wanted to let you know we at Aetna are excited to announce that we are having our first virtual roundtable event next Thursday, which is the 11th, from 12 to 2. We do have registration up, I think, on our website. I'm also going to drop my email address in the chat. If you haven't seen that registration come over and you're interested in joining, please let me know. I'll send that information to you. We'll be touching on topics such as systems, issues, claims, any upcoming events or trainings that we're going to have. It's going to be a really, really informational event. So, and we have great we have had great response. So I think right now we're sitting at over 100 attendees so far. So, but we want to pack the house. So if you're interested or any of your staff want to jump on that next week, please let me know. Second of all, we are going to wrap up our virtual office hours for this year on December 9th. Due to the roundtable event, we will not be having one next Thursday. But on December 9th, we will be hosting that virtual office hours for our providers at 11 a.m. You can register or get the call-in information on the website under the events tab. We'll be touching on some SCI issues. We'll have some clinical folks. It's a very informal training, so we would love to have you and your staff on that last one for the year. And I think that's all. Oh, one more thing. Our COVID incentive payments are coming out this week or next. So look for those. If you have any information on that, please let us know. We've seen a large increase in our members getting vaccinated, so that it's working. So we are very happy about that. So you guys have a great day.
Okay. Thank you so much. Next is Humana Healthy Horizons. And I'm not sure if it was Kathy Stevens or Beth Day that was here last time.
Hi, this is Pam Trigilio. Beth Day is actually out today. She normally does these updates. Good morning, everyone. I wanted to share that the newest edition of Humana Physician News, it was released today. So you should be getting that into your email inbox. One of the highlights of that edition is the brand new Provider Marketing Resource Center. The PMRC is a storefront that providers can access directly with the library of customizable patient-facing marketing templates. Those can be downloaded and bulk ordered or sent directly to their patients. If you did not receive this newsletter in your email, you can visit the humana.com website under News and Publications to subscribe to that. And then we would also love to hear any feedback that you might have about that newsletter. So please contact your provider relations representative if there are any topic suggestions or feedback that you might have. Also, be on the lookout for our upcoming edition of the Humana Healthy Horizons newsletter, and that is Medicaid specific. In that version, there's some important information concerning the PCP patient panels. And that's all that I had to share today. Thank you.
Thank you so much, Pamela. Next was Passport Health Plan by Molina Healthcare. Last time, Shelley Fife was the spokesperson.
Hi, yes, I'm the spokesperson again. Thank you all for giving me this opportunity. So as I mentioned during a previous meeting, we began offering a special incentive to all members, encouraging them to get their COVID-19 vaccine. I'm happy to state that since this began on June 1st, as of mid-October, we have had 3,327 beneficiaries claim their incentive. So that's pretty great. It seems to be working. We're also pleased to announce that we have partnered with Teladoc. This is to offer our members virtual care. They can connect to a board-certified doctor by phone, video, or mobile app from anywhere. Last but not least, I did want to mention that we are promoting the usage of KHIDE during each of our monthly external joint operating committee meetings. We're encouraging all providers to connect with the exchange. Thank you for giving me this opportunity to share our updates.
Thank you, Shelley. United Healthcare, Dr. Cantor was speaking last time.
Yes, good morning, everyone. Thank you for having me. I appreciate it. I'd like to first thank KPCA for allowing us to attend their conference last week and host a booth that was well received, and we appreciate that opportunity. I wanted to give a brief update on COVID vaccinations. Our member incentives are going well. We're providing a $100 gift card, as I've talked about in the past. And now that the FDA and CDC has increased that age down to the 5-year-olds, 5 and above, that incentive works for them as well. So I just did want to make that call out to that. And lastly is our portal for all of our providers. always has the latest and greatest information and small facts and tidbits that may be there. So it's just a good resource to always be able to go to our portal. With that, thank you for the opportunity.
Thank you. That finishes the announcements from the MCO. Next 5C is recommendations to the MAC. We already have the one that was voted on earlier today. Is there any other recommendations to be made? Having heard none, we'll move to 5D, confirmation of chair to attend the MAC meeting on November the 18th, 2021 at 10 a.m. And I will be in attendance at that meeting. The next item is under 5E, new items for discussion. Is there any new items, committee members, or anything you would like to bring up at this time, or anything from DMS? I understand that Veronica has stepped out and Lee is standing in forward. Lee, guys, do you have anything you would like to address at this time?
No, sir. I was just leaning in to take myself off mute and say, I don't think I have any news to offer or any discussion items to offer today.
Okay. And let me ask this. There has been discussion concerning the closing out the patient charts between the difference of 1 day for FQHCs and 3 days for other. And my understanding that that is something that intends to be made consistent for 3 days for FQHCs, RHCs. Do you have any idea of what progress, if any, has been made towards that?
What I can say about that is, unfortunately, given the last, I don't know, 18, 19 months, the work on more administrative-like changes in the regulations was pushed quite a bit due to, needing to issue emergency, more emergent regulation changes. So it's on the list. It's being worked on. We're trying to file as many regulations as we can before the session starts. I do not know where that is on the list to be accomplished right now. But if you leave it on the agenda, maybe we can give you a better timeline next time. Okay.
Thank you on that. Is it fair to say that the department recognizes the inconsistency and while it's on the books, that we would be more in line of expected to comply with the 3 days rather than the first days for FQHCs?
I don't know that I feel comfortable going that far as what you would be expected to comply with. Sorry about that. I think that certainly we understand the inconsistencies and are planning to correct those and make that reporting notification or signature requirements consistent across all provider types.
Okay. Thank you. I have one other thing. You heard the MCOs many of them talking about the benefits that or incentives they're giving out to encourage COVID vaccination. And each one differs in what they do. Would it be possible for the DMS to make a crosswalk of what the different MCOs and what their incentives are? Because when we asked our people actually there on the ground giving out the shots and providing information, it gets confusing for them. And if we had such a document, like a one-page document that we could in turn share with people as they get their vaccination. I believe it would help us to be able to get that information out.
Okay, so just let me be clear. You're asking for like a one page that says the MCOs are offering incentives if you receive the COVID vaccine, and here's what they all are, and list the MCOs and list what their respective incentives are. Is that what you're asking, just to make sure?
Yes, it is.
Okay, okay. I'll take that back. I don't see any reason why we couldn't put that together.
It would be very helpful.
Okay.
Any other new items for discussion at this time?
I don't have any, Mike.
Okay. Any other committee members?
None.
None.
All right. So I'm sorry. The next meeting under 5F, next meeting is January 6th at 10 a.m. With scheduled bracket time to 12:30 p.m. And as far as I know, for the 2022, our meeting dates will correspond as they have this last year, unless anyone finds those meeting dates in February, what we got, January, March, May, July, September, November. Unless anyone has a problem with those, that we could expect that will continue to be the same for 2022.
Mike, this is Teresa. Just for clarification, we usually have it on the first Thursday of those months. So those dates would be January 6th, March 3rd, May 5th, July 7th, September 1st, and November 3rd.
Okay. Does the September 1st date conflict with Labor Day by any chance?
No, it's a Thursday.
Yeah. Thank you. It's nice to know that my mind is slipping somewhat as I get older. So forgive me on that. So that'd be the meeting dates. That'd be the meeting times. Is that suitable for everybody?
Yes.
Yeah.
Okay, by me.
Yeah.
All right. Just for clarification, can someone adopt that in the form of a motion?
So moved.
Motion made. Is there a second made.
Chris.
Is there any discussion? There being discussion, all in favor of meeting dates for 2022 be as discussed, say aye.
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 All those opposed say nay. All right, motion passed. This brings us up to item 6, which is adjournment. The motion in favor of that, please.
So moved. This is Barry.
Is it a second?
Yes, Chris.
Motion made and second. All adjourned. Thank you so much for attending.
Thank you all.
Thank you.
Thanks, everybody. Stay safe.
Talk to you in January.